Good evening, folks. This is Dr. Paul. Thank you very much for tuning to our channel today. And today I want to talk a few minutes about opioid antagonists. So basically, like we are concentrating on the agents that block the actions of opioids. And I was reading a book this morning, like there was this professor of mathematics, Eric Lander. He had a PhD in mathematics, and then he went back to school to study biology because he wanted to apply the geometry and algebra to biology, like basically into the intracellular process, like the nucleus, the DNA and RNA and the genetic code. And one of the genes, like it has like 42 nucleotides, and this gene he called meaning of life gene. And supposedly, because this gene is present among all vertebrates, it gives the meaning of life. I mean, ridiculous stuff. Interesting but ridiculous in the sense because we don't get meaning of life from our genes. And another aspect to life is using drugs or opioids. There's like a certain subset of people who are on opioids all the time to get that euphoria, that feeling of I am so feeling well, this goodness feeling. For example, if you give morphine injection, patients get this floating sensation. Wow, I am floating and floating. That kind of sensation. I mean, it's a well-being. I mean, we all have these feelings of well-being. Like when I was in high school, like I used to call home and what is getting prepared. My mother used to say, we are making chicken curry. So I used to say, chicken curry. Man, I got to go home and eat chicken curry. And sometimes my mother used to say, we are making biryani today, lamb biryani. Oh, I got to go home and eat. So you see, this sense of gratification. Some people will have in food, some people will have in sexual pleasure, some people will have in drugs. And opioids are there. I mean, this is not new. I mean, if you see into Greek civilization, and two of their most famous goddesses were the Diana and Demeter. So Diana, the temple of Diana in Athens, like there were like people would line up because there was in temple of Diana there were like 1,000 prostitutes. They were actually the priestesses offering sexual favors, and these devotees would go to the temple of Diana to have sex with these priestesses, and it became like a form of worship. So that the temple of Diana on one side and the temple of Demeter on the other side. And the Demeter, if you see her picture, she has these poppy seeds as a diadem on her head. Poppy seeds, so that's basically opium. The people used to drink a cup of opium, and then they go around to worship the goddess Demeter. And after Demeter, they visit Diana's temple to have some sexual pleasure. So sex and drugs, that was 2,000 years ago, and that has not changed much in our world. But unfortunately, even though the same things that gratify our flesh, but there are serious consequences. And that's what we are going to talk today. When people take opioids, what is going to happen? How they are going to react? And unfortunately, folks, many people are dying. My heart breaks when people take all these Vicodin, Percocet, Oxycodone, Dilaudid, Diva, the hydromorphone, all kinds of things. And even grandmas are dying in some places because of the drug overdose. And sometimes if these grandmas like 70, 80 years, well, let them go. But what about these young people who are losing their life to these drugs? That's very, very sad. And I want to talk this evening about opioid antagonists that are very, very important in the clinical practice, because many times these are the only agents that help you to prevent a death. So these are the pure antagonists: naloxone, naltrexone, and nalmefene. And you see, interestingly, these are morphine derivatives, and they have these bulkier substitutes at the N17 position. So if you take the morphine, its atomic structure at N17, you're making a bulkier substitution in N17 position and producing these derivatives: naloxone, naltrexone, and nalmefene. And they have this affinity for I would say the receptors, like three receptors in the brain when you talk about opioids: the mu receptors, the kappa receptors, and the delta receptors. And the mu receptors are most important because whatever acts strongly at the mu receptors is the will be having most important effect on human body. So most of these powerful opioids will act as powerful agonists at these mu receptors. So if you want to create a powerful antagonist, you need to find something that acts strongly at mu receptors. So these morphine derivatives, naltrexone, naloxone, and nalmefene, they are pure antagonists at the mu receptors. That's why they are very, very useful in antagonizing the actions of opioids that primarily act through the mu receptors. So this affinity is what it matters. You need to reverse that agonistic activity. That's how you save a life of somebody who got, for example, respiratory depression or in some coma because of these medications. So the naloxone is usually given by injection, and it has a short duration of action, like 1 to 2 hours. That's a very, very important point. I mean, you will come across like 1 million drugs in a medical textbook, and sometimes you forget about their their half-life. Who cares about it? And that's fine in many cases, but there are certain drugs where their half-life has tremendous consequences in their clinical importance. And one of those drugs is naloxone. It has short duration of life, and it has a rapid first pass metabolism. So then we need to think about naltrexone. It has a half-life of 10 hours, and it is if you give a single dose of like 100 milligrams, it impacts. I mean, if the patient, for example, is given a morphine or a heroin injection, it antagonizes that action for a while. Then we have nalmefene, the newest medication, and it's a derivative of naltrexone. And it is also it's available only as an intravenous administration preparation. And like naloxone, nalmefene is also used for opioid overdose, but it has a longer half-life, like 8 to 10 hours. So the half-life: naloxone 1 to 2 hours, naltrexone, nalmefene 8 to 10 hours. They have longer half-life, they are more useful, but unfortunately they are also more costly. So what you're seeing here is like when you use these medications, basically you're producing that antagonism in these medications. And when given intravenously to a morphine treated patient, they produce antagonist immediately. So they go into withdrawal symptoms quickly because naloxone, it reverses the opioid effects within 1 to 3 minutes. So in individuals who are like acutely depressed by an opioid overdose, what is happening? Sometimes they cannot breathe, and you have to bring them back. What are you going to do? You have to give naloxone, and it changes the whole picture. And they get awareness immediately. They get the breathing immediately, and many times they immediately talk to you. So it's very important to keep a vial of naloxone with you all the time because drug use is increasing. So you see the naloxone you can give intravenously, naltrexone, and then nalmefene given intravenously. So remember the half-lives of these medications, because why I'm saying this is like sometimes what happens is, for example, if you say the patient has taken some opioids, let us say like that, and you give naloxone to this patient, the patient comes back to life. But what happens after 2 hours? The opioid actions may be continuing, right? And the patient will relapse into coma because the naloxone effect wore off. So that's a very, very important point you need to remember, because I had one patient coming one day, we put him in the ICU, we gave him naloxone, he came back to normalcy, breathing well, talking well, alert, communicating with his family. But the next hour he went back to coma. What happened was naloxone effect wore off, but the opioids he took the previous day, they were still continuing to act. So the devil never left. So you cannot just give one dose of naloxone and say, this patient is now normal, he is breathing well, talking well, communicating with his family. You always make sure you give again. I mean, you're not going to kill a patient. For example, even if a patient is not on opioids, if you give them naloxone intravenously, they're not going to die. It will be neutral in their blood. So that's an important point I wanted to stress this evening. So always remember, the naloxone has a short half-life, and you always need to keep an eye on the patient, and don't just give up after 2 hours. Yes, the patient came back, but naloxone's effect may wear off, and the patient may relapse into coma and die in spite of being given naloxone. So that I thought that's a very important point, because I saw that happened to one of the patients who was under my care, but fortunately he survived because we found and we repeated naloxone doses on him. So let's move on to the other points now. So it's a very, very important to remember these half-lives, the short duration of naloxone. All right, then, as I said, there are 3 receptors, the mu receptors, the kappa, and the delta. And we need to find a medication that acts powerfully at the mu receptors. One that acts powerfully at the mu receptors is going to help us in antagonizing the effects of opioids. And the usual initial dose of naloxone is like 0.1 to 0.4 milligrams you give intravenously, and in a life-threatening situations that's going to help a lot. Like, for example, if a patient got respiratory depression or CNS depression, you give maintenance dose like 0.4 to 0.8 milligrams intravenously, of course, and you can repeat the dose as necessary. And using naloxone in severely depressed patients, it is important to use more dose. And also don't forget the babies. Many times women use opioids throughout the course of pregnancy, and then the babies might develop respiratory depression, and in these babies you need to use naloxone. And you don't have to remember all the doses and all of that, because nowadays you can pull up any kind of a smartphone and pull up these doses. It's not a big deal, but the point is that you give naloxone even to the babies who are suffering from opioid overdose. So the careful titration of naloxone dosage, and that's important there. Now let's move on. Naloxone, interestingly, also helps with itching, nausea, and vomiting. And you know all that stuff like when we give opioids, they increase the release of histamine from mast cells, as you know, and the patients develop itching many times around their nose. People say, "Oh, I got my nose is like itchy." That's basically the opioids release the histamine from mast cells. What naloxone does is it decreases the release. That's why naloxone is good in eliminating nausea, vomiting, and itching. And the good thing is it does not interfere with the analgesia. So a patient who is taking opioids for pain can also benefit by using naloxone, because naloxone takes away that itching, nausea, and vomiting while giving relief to the patient while still giving the not affecting the analgesia aspect to it. So you see the importance. Now we have other formulations like methyl naloxone, for example, is being used to treat the constipation. Opioid-induced constipation is being treated by that. Then alvemopan is there, and it's used in the treatment of post-operative ileus following bowel dissection surgery. So naloxone can treat constipation induced by opioids. And how is this acting? It's acting again through the through the inhibition of peripheral mu receptors in the gut. So naloxone, basically the opioids are acting through the mu receptors in the gut, right? So naloxone is inhibiting those mu receptors in the gut, and it is increasing the peristalsis. That's why patients are treated. So the opioids acting through the mu receptors causes constipation, whereas naloxone acting on the same receptors in the gut, it increases the bowel movements. So that's another good effect of naloxone, and many preparations are now coming out, like Relistor is naloxone derivative used for the treatment of constipation produced by opioids. So you say that's naloxone in the opioid overdose, and then to treat itching, then to treat constipation, and then there is another use like you take morphine. There is a medication called Embeda, and you take the morphine pill, and inside it you put a little bit of naloxone, and you give it to the patients. Why? Because there are people who will grind morphine pills and they inject intravenously. What happens is, if they do it, naloxone immediately makes them to go into withdrawal, and abstinence syndrome would be produced. So you're putting a little bit of naloxone at the center of morphine, and they ingest it, nothing happens. It will be digested and goes out of their system. But if they grind it and take it intravenously, it can cause serious problems. So that's another use of naloxone. Then we also have other uses like I would say in alcoholism, you can use naloxone. For example, there is Vivitrol right now for people who are suffering from alcoholism. You can use Vivitrol. You can give Vivitrol like a monthly injection, an intramuscular injection. If you give monthly, that Vivitrol, those basically those naltrexone will go out into their body, and it gives them protection, because basically it increases beta endorphin level in their body. So naloxone in that way. So opioid antagonists are useful in that way. There is also evidence naltrexone decreases the craving for alcohol in chronic alcoholics by increasing baseline beta endorphin release, and it is also been approved by the FDA. So you say naltrexone being used to treat alcohol dependence. Naltrexone also facilitates abstinence from nicotine. So Another use is like cigarette smoking. So now we have many different things like nicotine patches and Wellbutrin, Chantix, and all these things. But you can combine these medications with naltrexone, and you will see a greater effect. Same with weight loss. You give naltrexone and bupropion, and they produce weight loss. I mean, if they like, there are studies right now going on to see the cardiovascular effect of these medications, and in the future we might see naloxone in weight loss treatment, naloxone in smoking treatment, naloxone in alcoholism, and all these things. So you see, there's a wide application of opioid antagonists, and you can read about more in a medical textbook, and those are the things I wanted to share with you this evening, and let's meet you some other time. Thank you very much. Visit my website www.drpaul.org, and you will find many videos. Thank you very much.